Mark White here, Idaho State Planning. I'm the chief cook and bottle washer. We're a small office, and in all fairness, I don't do that much. I am the face of the organization, and that maybe is an issue. Dr. Louise Liew is with us. Dr. Louise, you've been in the Treasure Valley now for a few years.
Almost 2 years now, yeah. It's been almost 2 years.
Oh my gosh, you've been kind of busy in that much time.
Just a little bit.
Yeah, how do you like Idaho now?
Oh, I love it. I mean, we're definitely not going to go anywhere. So, I mean, we're staying here for quite some time.
Excellent, very good. A couple of questions for you, just kind of by way of introduction. You are a medical doctor.
Yes.
But you are practiced in the ancient art of acupuncture.
That's correct. So I did acupuncture right before medical school, and I was able to travel to China to apprentice with a master. So it was really cool. And then 24 hours later, started medical school, coming back.
Awesome. Now, I know doctors tend to get to do a number of different things, but one of your areas of emphasis or focus is geriatrics. Can I say that?
So I did an extra year of fellowship at USC to really focus on being a geriatrician, because there's definitely a need for doctors that can focus on a more complicated, as they're, advancing in their age, in their medical care, because unfortunately a lot of patients at a certain age, they end up on quite a bit of medications. And so my goal as a geriatrician is to help everybody age gracefully and help people, get to the next stage in their life with minimal number of medication and as healthy as possible. So yes, I do focus on geriatrics, and my specialty does focus on how to minimize the medications, how to prevent dementia if we can, or how to slow down a process of dementia, and how to get diabetes, congestive heart failure, hypertension all under control.
Worthy goal, lots of work.
Yes. Lots
of work. Well, today we have you as our guest because we're going to talk about end-of-life planning, which, in my experience, is extremely underserved.
Agreed.
So in our office, we talk a lot about the plan by design and the plan by default. And so let's talk maybe just a minute about if you don't have a plan.
Right.
The government has a plan for you, and not because they know you personally, not because they're looking out for your best interests, but if you haven't done a plan, there's got to be a way to get certain things done.
Right.
So the way that plan looks, as far as, say, I become incapacitated and cognitively not able to make decisions for myself. If I don't have anything in place from the legal standpoint, we're going to go do a conservatorship or a guardianship, which from one standpoint is great because we've got something as opposed to nothing. But then we're subject to the jurisdiction of the court, and some of our planning, then we need a court order to get that done. I don't know, in the last couple of years, have you been involved in any of these?
So yes and no. So I have been peripherally involved in quite a bit of the case, especially patients who have not the capacity to make their own decision, specifically with family members who feels, what their thoughts are is the best interest of the patients. So the main thing is having that conversation with all of your family members and really enabling and assigning certain family members into the roles will make the process a lot easier versus the family members that have to make their own decision about who's going to take over and what not, and it may not coincide with each other. And so that's when the government and the ethics committees come into play, because the patient never verbalized how they wanted to proceed if they didn't have the capacity to make the decision. So I have been in those case situations where the families are on different sides, and then we make the recommendations, and we just have to come to a decision. So we have been in through all of that. But I haven't actually, fortunately, knock on wood, that I have ever been gone into court to advocate. So,
well, the big thing, the big takeaway from being involved in a court process, and I used to do, I've done a number of these. The takeaway, though, is that we bring more people into the process. To do a conservatorship, there's a guardian ad litem, there's a friend of the court, and then there's an attorney that brings a petition, and often an attorney that's appointed for the individual that we're trying to protect. And I don't know if people realize this, but if you have 4 attorneys being involved in a case, it can get rather spendy in a hurry. And then we get, from the medical side, we'll have a doctor that's involved as well. And so we may end up then, after we get all that involved, we may come back to what you were talking about, is getting an ethics committee in, and we've got, to give the judge some help in making decisions. And we can avoid that. So that's the default plan.
yes.
And by the way, for the finance side, that's a conservatorship. For the healthcare, the medical care, that's a guardianship.
Mm-hmm.
And while they're 2 different things, we often do them together if somebody's in that situation. So that's the default plan. It can be expensive, time consuming, and I just got to tell you, if you're bringing mom in to have her declared incompetent, the judge makes a legal determination that she's incompetent, that's not fun. That just isn't fun. So add to all the rest of that, it not being fun, I recommend strongly that we avoid that.
I completely agree.
And make those decisions beforehand, meaning we have the ability to be in control. We just have to exercise it now as opposed to later.
Right.
So let's talk about some of the things that we get involved with. One is a healthcare power of attorney, which allows me to designate somebody who can make medical or care decisions for me if I'm not able to. Do you get involved with discussing the healthcare power of attorney with your patients?
I definitely do. So one of them, especially if the patient is exhibiting any type of memory loss, it's extremely important to have a healthcare POA, power of attorney, available, because obviously one is just to help them understand what happened during the whole medical visit. How can we proceed, and what can we do to slow down any type of medical concerns that we may have? So healthcare POAs are the ones that we try to do our best to figure out prior to finishing the whole entire visit, so that we can involve everybody, so that we can give the patient the best care possible.
So for us, when we have this discussion, we love to have the family be involved in this conversation, because, well, most of the time it's a family member. And if we can have we call it a family meeting. If we can have the family meeting, then hopefully we're avoiding that situation where you got the 2 older kids and the 2 younger kids, and they're not in agreement. And so I love what you're doing, having that conversation, so all the kids can hear what mom or dad wants.
Exactly. And it's important. And I always tell my, even the people who are already assigned as healthcare POAs to please keep the communication open with their siblings and their loved ones, because when something happens and maybe the healthcare POA is not available at the time, at least if other family members have an idea of how they want to proceed. So it's always a good idea to kind of have a lineup of their family members or their friends' involvement so that we can abide by the patient's wishes.
Yeah. And when they have moderate to severe, I've noticed on every commercial for a pharmaceutical that it's only for moderate to severe, whatever it is.
Right.
It's moderate to severe plaque psoriasis. I pulled that one out. But when they get to that point with cognitive issues, it's really late in the process, and they're not going.
Too late.
Yeah.
It's completely too late. And if something changes during that time, I would question it. I would have a lot of questions in regards to why this was changed at such a late, decision making. And so I would not be able to abide by what they changed at that time because they do not have the capacity to be able to make that kind of, it's a life-changing decision essentially, right? And so moderate to severe, especially severe, when they barely are verbal and somebody's asking them to sign something, that's completely wrong. That should not be, that would not be legal with me.
Got it. So it's hard to be too soon to have this discussion. It's hard to be too early.
That's right.
In a situation to have this discussion.
It's true. It's definitely true. I mean, I had a discussion with my entire family when I was giving birth with my first kid, because I've delivered babies, I've seen the complications, and I've had a full-on conversation with both my mother and my husband in regards to what I would want to happen to me if something happens. And so it is never too late to have a discussion. I had one attending when I was in residency who said every Thanksgiving they went around the table so that everyone can hear what they wished for. It included their kids, it included their mothers, fathers, in-laws, everyone, so that everyone knows how to abide by their wishes essentially.
Well, and it's interesting. An observation is when we can get mom and dad to start focusing on this planning, and it's the planning for the estate, it's planning for the kids, but it's also to make these end of life decisions. When we can get them to sit down and think about this without crying. We have the kids that come in and they sit there and bawl the whole time. Okay, not all of the kids, but we often have somebody in there that's just absolutely struggling with this. And I feel bad, but, points for mom and dad to have everybody involved and to be making these decisions.
I completely agree. And it is, of course, it's one of the hardest, discussions we ever have to make, right? But it's necessary. And when the patient comes into my office, no matter what the age is, one of the questions on a first visit is whether or not they have an advance directive. Because then I know you never know what's going to happen. And we have to prepare for it. We have to be ready for the inevitable. We have to prepare for the unknown, the accidental, everything.
So I don't want to go to the advance directive just yet. I want to talk. So this is the healthcare power of attorney. The concept at the higher level is simply enabling people, giving them the authority, and we'll talk about directions in a second, to make decisions about our healthcare if we can't articulate it, if we're not making good decisions. then that's what the healthcare power of attorney does. Before we jump to the advanced directive, I wanted to talk about Hipaa. Because this is an area that is often overlooked, and my compatriots in the legal profession often overlook this as well, meaning that a doctor, medical care providers have to have permission to share my information with other people. Now, in Idaho, if I'm the spouse, I've got probably most of the doctors would share information with the spouse. But if I have kids come in and the doctor doesn't know they're my kids, that makes it a little more difficult to share that information. It's the Health Insurance Portability and Accountability Act. It had nothing whatsoever to do with the privacy of your information,
Right.
other than they put this provision in there. So let's talk a moment about giving that information. As a doctor, do you ever get hung up going, I don't know who you are?
Completely. I think I emailed Carly a few months ago in regards to that, because with the HIPAA, even when the patient's deceased, we have to abide by the rule and figure out who we can share information with. I know there are some rules where you can't share information for up to 15 years. And so it's extremely important to be able to let us know in the medical setting who we can share the information with, because a son or a daughter may be estranged, and then they show up randomly and say, hey, I want all my parents' medical records.
Yeah.
We're not going to share that unless there's a name written on the actual form that says we can share the information with.
For us, one of the first people to put on that list, here's my permission, Dr. Yee, here's my permission to share my information. And one of the first people I'd put on there is my healthcare power of attorney.
Correct.
Hard for them to do their job if they can't receive information.
Correct.
So they can tell you all they want all day long, but you're stuck in getting that information back. So that's one of the first people. I would certainly put a spouse on there just because.
Right.
Just because. Now, for folks that are not married, and they have a significant other, I think it's incredibly important to get that person listed on the HIPAA.
Agreed.
And so that's a situation where, say, a same gender situation, that you've got to put that person on there so that they can get information from the doctor, because that may be the most important person. And if they're not related and if they're not married, that puts you in a really tough spot.
Mm-hmm. Agreed.
So just had a question. Is this healthcare durable? So I'm gonna shift for a second, Dr. Louise, and I'm gonna talk about legality for a second. So when you have a durable power of attorney, that term durable refers to whether or not it's still valid if you become incapacitated. If you're incompetent, is your power of attorney still valid? Well, in the estate planning arena, we do. There's no reason not to make the healthcare power of attorney durable. Otherwise, it really doesn't work. So you'll often find the language in there that says this is a durable power of attorney, which means if I become incapacitated, then my agent can still make those decisions for me. Sometimes with a financial power of attorney, you make it very specific and you don't make it a broad durable. We don't do that often because we really need the help if we become incapacitated. So this will be a durable power of attorney it's valid when I'm incapacitated. Okay, so HIPAA release, some forms for the power of attorney have a provision in there for the HIPAA, and provide where you can write in the people that you have. Let me ask you a question. We tend to put all the kids on the HIPAA, not just the people that are making decision, but all the kids, because this part of the country, anyway, they tend to gather. The family tends to gather. And so we end up putting the kids on there so that they can get that information. Any thoughts on that?
So what ends up happening with that one is we always ask our patients, even though you've listed all these people on your HIPAA, is it okay? Because it's not the capacity to make their own decision, right? Is it okay to share the information? So we always verify who we can share the information with, even though they may have written it down, because we still take their verbal with the capacity over the HIPAA. And I think that's important because, every so often we do get calls from their kids who want to say, hey, you know what? Dad can't make the decision for mom, and we think that dad should be doing this for mom, and so forth and so on. So, one of the main thing is we always say we are more than happy to run a family meeting to see where the disconnect could be, so that we can always make sure that everybody's on the same page. We usually try not to take one word over the other, because we're not living a life, so we cannot make any type of decision based on what he said, she said.
Right.
So our biggest thing is, even though the patients may have listed everyone on the HIPAA, we always ask, if so-and-so calls, can we share the information? And let's just say that we didn't get that, get that confirmation before we share information to them, we still call the patient and make sure that that's okay to share it. And that's just because we really don't want any type of confusion about what is happening, because we truly feel that the healthcare power of attorney should be the one making the decisions and being completely and well informed, and they should be the one to be allowed to share the information unless they're specifically asking us to give out the information.
Got it. We're very clear that even if we have family members that are on the HIPAA release, there are only a very few that they've chosen that can make the decision. So we make sure that we got that, because that's crucial. They got to understand that not everybody on the HIPAA release gets to make a decision. It's
Correct.
Only on the healthcare power of attorney.
Correct.
And that's critical. So HIPAA release, when we do the other estate planning, if we have a will or a trust, and with the financial powers of attorney, often those people need to understand from a medical standpoint what's going on, so that they can plan for it. They can take the steps necessary to make sure everything happens the way Dad wanted it to happen. Okay, so now let's talk about the advanced directive, which is a great name, as opposed to living will, which is a dumb name. I'm not sure why we chose it. I think the state legislature was going, well, listen, we got to have people making, doing this planning, and instructions to let me die. I think that was proposed, and they said, no, that isn't really a good name. So they picked living will, even though it's really not about living, and it's not a will. So I like advanced directive a lot better. So let's talk about the advanced directive for a second, because I think a lot of people look at this and then don't maybe understand the impacts of the different things that are going on. And when we talk to clients, we kind of emphasize that there's really three basic concepts here. I call it the everything, the nothing, and in between. And everything is plug me in, keep my heart beating, breathe for me, do whatever. Which, in 35 years, we've only had maybe 5 people that have picked that one and said, I want everything. Do you see any of that?
I agree. I agree. Most people pick more of the modified and do not do anything and let my body naturally go.
Yeah.
Category for sure.
Yeah. So for most of the way these are drafted in the state form, in a second, I'm going to tell you how to get there. It's the third option that basically says, I had a good run. It's time to go. I don't want to be a burden on my kids or whatever. And so they choose, let me go. And that is by far, by like 90% that we've seen is, no, let me go. So I thought maybe, and in between, we'll get to that in a minute. The in between is, well, let me go if I'm not dead yet. Feed me
Right.
and water
Give me some fluid. Give me some antibiotics. But if my body doesn't accept it, it's okay to let me go. Kind of, that's the in between.
Yeah, very good. Thank you. So what I wonder is if people truly understand what that means on that first one, to continue to receive, for most of us, it'd be life support. Can you give us an idea of the impacts of that?
So one of the main things, when it's give me everything possible, that can include compression. And when we talk about compression, we're pushing down with quite a bit of force. And through every time I've run a code, majority of the population does have, unfortunately, a broken rib at the end of the compression, because again, we have to compress through the chest cavity into the heart to try to revive the heart. If we're unable to succeed with that, then we would try to shock the patient back into life, right? So that is actually the compression resuscitation portion of it. Let's just say that the heart is resuscitated. The next question is, am I able to breathe on my own? And so then a lot of times compression and intubation comes hand in hand. Majority of the doctors who are running codes are, one doctor is going to be intubating a patient while the other doctor is compressing the heart. When we intubate, we actually put a tube down into our lung area to help us artificially breathe in and out. There are some patients, obviously, when they're going through surgery, when they're going through a procedure, they do have a temporary tube down the throat because, their body is put into a deep sleep, so that we have to ensure that they're still breathing during the procedure. But when a patient have already either passed away or their heart and lungs have completely stopped, now we're doing artificial breathing, and we're hoping that their body will eventually be able to breathe on their own, which unfortunately I can say it's going to be a 50-50 chance. And as they're older and as they're more frail, the chances of them being able to breathe on their own is even more slim. And that's just because their body is not able to sustain the natural heart and the breathing. And so majority of the time, if they're really frail and they're pretty far gone, they usually are not able to be extubated, which means that a lot of times they're on an intubation for the rest of their life, or they have a trach that they're put so that they can still have the artificial breathing for the rest of their life. And so, and then besides that, after, let's just say we do revive the heart, a lot of times we have to put patients on pressors. That itself is medication to keep the heart strong enough and pumping as much as possible. And there are quite a few patients that are continuously on 1, 2, 3 pressors to keep their heart going
Mm.
because their heart is failing and it cannot sustain the continuing individual, pumping of the heart. So that's a full picture of what we would do as a full code, meaning that I want the compression, I want the shocks, I want the medications, I want the intubation. And like I said, some people may come out of it great, but usually when a patient is more frail or they have severe dementia, they're trying to pull out the tubes. And so they're really hurting themselves. And because they're telling you, even though they can't verbally tell you, that they don't want that, And so that's a full part of compression.
Yeah, that decision is really involved. And I think a lot of people, I think a number of people get to the right answer without thinking all the way through that. And that's okay, but I think the folks that choose that one, and like I said, we don't have a lot, that's really involved. So this is what's called the advanced directive or a living will that says if I am in a terminal situation, if I'm gonna die anyway, or if I'm in a persistent vegetative state, please let me go. Or let me go, but if I'm still hanging around, give me some food, give me some water. Don't let me starve to death. I have to ask this question, okay? This is if you're at that point, is it really going to be painful to die of thirst? I mean, if we disconnect and let you go, that's a big worry, though.
Oh, that's a
Dr.
big worry
Louise,
for a
you're
lot
sitting
of
there
people.
going, oh, I don't want to be thirsty. I don't want to starve to death.
Right.
How accurate is that in this, if we're dying, how accurate is that?
So what ends up happening is when you can't drink, when you can't eat, your body automatically shuts down. So you're not suffering, you're not torturing your loved ones by not feeding them or by forcing them to drink water. Water is a huge thing. A lot of patients think that if I keep giving them fluid, it's going to keep them going. But unfortunately, for some patients, it feels like they're drowning in their own body because they cannot digest the fluid that is being forced into them. So they could be still having urine output, but unfortunately, most people will notice that their body becomes swollen. And that's because it's something called third spacing. That's just because the body's not digesting the fluid that we're intaking and it can't release it. There's no output for it. So patients often feel much worse by forcing everything into their body because they can't digest it at all. Food-wise, the same thing. If I keep forcing them to eat and their motility in their gut is really slow, they become very constipated. They may have bowel obstruction, and it causes them more distress than help at that point. So, some patients may be opening their mouth and they may want to eat a little bit, and that could be it. The more we force, I feel like the worse they're going to feel because they really are not able to digest the food and the fluid any more than what their body wants. And so you're not torturing them. They don't feel that discomfort that we're worried about.
If we unplug them, okay, that's maybe a little abrupt way to say that. If we unplug them and let them go. So one thing to keep in mind, and I think this is important to note, that with a living will, there's a provision that we will keep you comfortable. So there will be pain meds, there will be maybe some ice chips, or we're not going to let your mouth dry up and be really uncomfortable that way. And I think that's important because some people don't understand. And I still know a number of clients that want food, they want water, and that always makes me uncomfortable. And I feel like I haven't educated them well.
No, it's not that. It's just, again, it's just the way we think, because to show love is to give, right? And so we're part of us, we don't want anybody to suffer, especially towards the end. But the most important is, like you said, education, educating the entire family and allowing them to understand that it's not a torture. You're not starving the patient. You're allowing their body to naturally go.
So I want to move on to one more thing that takes this decision a step further, and out of the legal side anyway. We are no longer involved with that, but I want to set it up a little bit. So if we have somebody who has a living will, an advance directive that says, I just want to go, but they code. And we have EMTs, paramedics, we have the first responders get there. They still got to respond, don't they?
They do. So the most important thing is, so patients through my practice, what I do is we actually give them a bright neon pink form that we ask them to put in a very visible area, whether it's on a refrigerator, back of the door, or whatever, so that if the patient codes or something happens to them and they don't have anybody around them, right, then at least when the EMT and EMS comes in, they're going to visually be able to see that, oh, wow, there's a bright form right there that says, do not do anything. The other thing is, if they do have family members that are living with them, have them know that if this happens to me, don't do anything for me.
Don't call 911.
Yeah.
If this is towards the end and I've made this clear, don't put them in a difficult situation.
Correct.
Okay. So I want to go one more step. I want to talk about the physician orders of scope of treatment, or the post. And the post is really the living will on steroids, if you will.
Right.
Because this now gets its name because the physician is the one that has signed on this. So if I've got emergency personnel that come to the house, and they see this, they're able to stand down and say, no, this is what they've decided to do. So if we can make this work, technically, I was going to put one up, but I need to have you make me the host again. You got it?
Yep.
All right. So I was going to share this screen and then let the doctor do what the doctor does.
Yeah. Okay.
Because this is a doctor thing. This is not the attorney thing, right?
Right.
Okay. So is it
this
sharing?
Is the one that I'm talking about, putting it in neon pink, because like you said, it's the Living Advance Directive on steroid. It's a beautiful 1-page paper. And so the EMS just has to literally go down each section. Within a few seconds, they'll know exactly what they want to be done. So the first section
is this sharing okay? Dr. Louise, can you see that okay?
Yeah, I can see everything.
Do you want to walk us through this a little bit? We don't have to get into the weeds, but just kind of, all right, here's what we're doing here.
Yep. So the first section is essentially when the patient does not have a pulse, they're not breathing, or they can have a very weak pulse, and they're having a very difficult time grasping air. So the first box that says full code means that, okay, this is where I'm going to do the chest compression. This is where I'm going to be able to do the shock to the heart if necessary. Do not resuscitate means that, allow the patient to pass away naturally. We don't touch the patient at all. Section B gets a little bit more complicated. This is where the patient may have a weak pulse, they may have a pulse, or they're breathing, but at the same time, they're having a very difficult time keeping keeping up with their heart rate, with their breathing. So the first one says comfort measure, which means that's not the modified. Comfort measure just means that please just allow my body to go naturally. Don't give me any type of IV fluids. Don't put any intubation. Don't do anything to help me. But you are allowed to utilize oxygen. So oxygen meaning the oxygen mask or the nasal tube to help with the breathing. Some patients may just need wound care, which is essentially when the skin has broken down because there's not enough protein or because the patient is completely bedbound and is not able to turn on their own. Those type of things, you're still allowed. You're still allowed the pain medication, the discomfort medication. Ice chips are okay. If patient can eat, we continue to give them food. If they can continue to drink, we continue to give them fluid and stuff like that. That's comfort measure. That's not any type of heroic measures. It's just comfort. Limited additional intervention means that, okay, a patient comes in, they need, let's just say that their heart is kind of weak. They're going through a congestive heart failure, but their heart is still pumping well enough. At that point, what we can do is we can try to give a little bit of medication, a little bit of fluid to see if we can revive the person naturally. They don't want any type of aggressiveness, which means that intubation or any type of cardioversion, meaning that shocking the patient back into rhythm. We're trying to allow the patient to naturally do it with just medications, but not with any type of invasive intervention. Aggressive intervention means that pretty much do whatever you can to help me. Intubate me, put me on a ventilation, do whatever you need to do to save my life. That's aggressive. And I usually tell patients that if they want to have comfort or limited or even aggressive, I always fill out the other instructions. Other instructions means like, hey, try it for 2 or 3 days. And then if I still can't, live naturally, then extubate me, let me go. That's okay. Or I can say, you know what, do one full round of full resuscitation, full, compression, everything. And if I can go, if I live, then great. But after one full round, which, as a physician, we do rounds with the intubation with the airway and with the compression, we do rounds. And you can say, do it for 5 minutes, do it for 10 minutes. And if my heart just doesn't come back, then let me go. So other instructions I feel is extremely important for physicians to fill out so that the paramedics, the ER physicians, whoever sees the paper understands that this is what they want. I still want to see if I will survive. I want to see if my body has not completely given up on me yet. But if it did, please let me go. You try to do this. Okay. Section C is essentially artificial. Feeding tube. Feeding tube means that we could possibly put an NG tube, which is a nasal gastric tube, or we actually do a surgery where we put a feeding tube into the colon and into the small intestine, large intestine to feed the patient artificially. And when that happens, the risk and benefit needs to be discussed. If a patient has cancer, right, and they need to have the artificial feeding tube because cancer is gone, but they can't eat anymore because either they have esophageal stricture or they have a lot of bowel obstruction or something like that, then a feeding tube will be very beneficial because then it allows them to keep the nutrition going. But if a patient is vegetative state, for example, and the family feels like, oh my goodness, they're not eating anything, let's put a feeding tube, it may not be beneficial at that point because you're prolonging somebody's life by artificially keeping them, rather than if it was cancer and I've beaten cancer, but I have now the side effects of radiation, chemotherapy, or surgery, and all I need is just some food in me to continue to survive, then that's a completely different scenario. IV fluid is usually for patients who, are majority of my geriatrics population, they're very dehydrated. And sometimes just giving them a little bit of fluid can revive them. Unless, a patient looks like they're having congestive heart failure and they're already fluid overloaded, then I would say, and that again is the other instructions, right? Because other instructions is going to give the paramedics and ER the idea of what they want to have done. And then there's antibiotics and blood products. Antibiotics can go through IV, it can go by mouth, it can go through, injections or whatnot. And depending on the severity of their septic, and they look like they should be able to survive without it, I definitely recommend to all my patients, do a trial of the antibiotics. If their body fights against it and they're, they recover completely, that's a great thing. Because antibiotics is not as invasive, it's not as much of an intervention that we have to worry about. And then blood products, could be dependent on religion preference, right? There are certain religions that absolutely refuses any type of blood products versus patients who just knows that they've gotten multiple transfusion and they know that they're still going to be losing more and more blood, and they just say, you know what, it's okay if I go, then I would say no blood products. But if the patient is just anemic and let's just say they come in, but they're, awake, alert, and their hemoglobin is 4 only, then of course, I would say definitely go for the blood products. But other instructions should be saying, based on my religion, based on a multiple transfusion, I want this, I want that. So those are all important. And then we get to the advanced directive where we talk about the living will that we've gone through, the DPA, which is the durable power of attorney, if they're assigned or not, and durable power of attorney healthcare and stuff like that. So those are all important for us to fill out.
So this is where we have to step aside. This goes to the doctor. We attorneys think that we're all that and a bag of chips. But if we sign this, then emergency personnel, hospital staff, they'll look at it and go, yeah, that doctor of laws, it doesn't cut it here in the hospital. So they need your signature on this.
Right.
Question for you. And I recommend it to everybody when they come in, because our clients are usually a little older. They're retired, approaching 70 or better for the most part. So I suggest it. Now, but I'm going to ask you the question. When should somebody sit down with their doc and put together a post?
As soon as they can. This can be constantly changed. This could be changed every 2 seconds if they wish, but this needs to be done. I always have my patients fill one out on their first visit, unless they already have something, in writing. I think I have it. I'm in my 30s and I have one already because there are certain things that I don't want. So everything like this should be done with each annual wellness exam. So when a doctor goes over a nice, beautiful summary of how your health well-being is, this should be asked. This should be said, hey, we don't have to fill this out, but let's discuss this. Let's have you take this home, read it over. If you have any questions, bring it back and we can work on it together. But this should be done with every single patient, whether it's the first visit, the third visit, it should always be brought up and we should have it on file as a physician and and obviously personally too.
Yeah. So when we put their plan together, our job as attorneys is to get that interpreted onto documents so that they're words so that people can follow that.
Right.
And we put together all their documents. So section D, we're saying, here's the suite of documents you should have. The living will, durable power of attorney, which we visit with them about anyway. Durable power of attorney for healthcare, but the crown on top of that, if they want to be in control, is this physician orders of scope of treatment, because that kind of fills in all of the gaps and then allows them to to go if that's really what they want to do. Now, if they don't, they need one of these as well so that they can give the instructions. And it has to be signed by a doctor.
Correct.
And so again, my Juris Doctor is not enough. You need to go to your doctor and get that filled out. All right, Dr. Liew, awesome. Thank you for being with us today.
Of course, thank you.
I haven't seen any other questions. If you have some, we got just a couple of minutes. Be glad to answer those. Glad to have everybody with us today. Dr. Liew, great to see you again. I need to come in for some acupuncture.
Yes, come on in, Mark.
And get poked with the little needles. I have some anxiety.
Not that way, Mark. It has to be this way.
Oh, this way. I have some anxiety about that. Okay, just a little bit.
Don't worry. Once the needles are in, it relaxes your body completely.
Okay, I'm taking your word for that. Taking your word for that. Anybody else got a question or a chat? We're gonna shut this down then. Again, thank you all for joining us today. Hope you have I see a question. Hang on. A couple of questions here. One is they would like your contact information. And so we can, since we've got everybody here, we can get their information, get your information to them. Do you want to give us a good phone number for you while we have everybody here?
Yep, I'm doing that right now. So I'm under Brightview Health, and then our phone number is 208-509-8987. And so, we pretty much take all insurances, and I really love seeing patients and really having a discussion. I'm very comfortable with pretty much discussing anything and everything under the sun. So, bring in the question, if anybody comes into the visit, please bring in all your medications, because a lot of times, including supplements, that's very important for me too, because supplements and regular medications have a lot of interactions. So I do like to review everything that you're putting in your mouth, essentially.
Very good. Then somebody else asked if the recording will be available. Yeah, we're going to edit it a little bit, just usually on the front end of the back end. Everything else, you just get what we got, what we gave today. And then we'll post that to our website. So that'll be idahoestateplanning.com, and we'll post that, the recording, but we'll post it basically as a podcast. So you should be able to link that and get on and watch this again. Any other questions that people have today? It's good to have you here. I think we're going to shut this down. If you've got something else that you want to talk to me about or talk to Dr. Louise, I can tell you that she's just awesome. You're going to like visiting with her. Thank you all. You're welcome. Yes, I thought it was a good chat today. I'm glad that you were on. I got, somebody's asking about seminars on trust versus wills. So since these are our lunch and learns, that's going to be one of them. So we'll keep you all posted. Very good. Gonna run. Thank you all so much for being with us today. Hope you have an enjoyable afternoon. Dr. Liew, thank you so much.
Thank you.
You're welcome. Take care.
Bye.